Skin talking about skin malignancies. This is a very big problem or an issue that a lot of plastic surgeons have to deal with. So we'll try to go through them quickly so that we can be done within the hour. So in terms of the objectives, all these objectives are the same for all of them. Even what we did last week, you can use the same objectives and you'll be able to understand the concept behind it. So these are the things that they might ask you to ask in the exam. So classify, define. Okay, they will not ask you define, but they might ask you the cells from which they originate, who is affected. So they might ask you questions, especially MCQs related to the epidemiology, how they come about, and you'll find that I'll be repeating a lot when I'm talking about squamous cell and basal cell carcinoma, and even malignant melanoma is something that will repeat a few things in terms of the pathogenesis. In terms of the clinical presentations, that's why now you find different presentations, and histologically they tend to look different. So that goes back to the definition. When you're talking about investigations, more or less the same. Staging also very similar, and then mode of treatment quite similar. So just very few things that we need to note for each one of them. The first one we're going to talk about is the rodent ulcer, which is the basal cell carcinoma, or what sometimes we call the tear cancer. The reason we call the tear, you'll understand in a bit, especially when you're talking about presentation. The tumor, what do you call this, tends to burrow into the nose and the surrounding areas. That's why it's called a rodent ulcer. Okay, and tear cancer because it presents around where tears, you'll find the tears. Okay, so what, how, and who? What is it? It is a low-grade neoplasm of non-keratinized cells of the basal layer of the epidermis. Remember, the epidermis had basal, spinosum, granulosum, lucidum in thick skin, and the corneal layer in all of them. Okay. So from the basal cells, where we tend to have the stem cells, that's where this cancer is coming from. Okay. It tends to affect mostly light-skinned people. And when I say light-skinned, I don't mean brown-skinned people, which is what we tend to have in Kenya. What I mean by this is Caucasian people. Okay. So for us, the darker, black, and brown-skinned people, it doesn't affect us as much. Okay. The most common cause is UV irradiation. Okay. And this is mostly in sun-exposed areas. That is in areas which are covered. That's where you tend to find, now for our population, that's where you tend to find this basal cell carcinoma. But the most common area you find is in sun-exposed areas. So people from sunbeds, there's usually some genetic predisposition, especially with the Caucasians. So other factors that increase are increasing in age. So the older you get, the more likely you are to have it. I said fair skin. I don't know whether it's in this presentation, but we have those classification up to 6. It's Fitzpatrick classification of skin. So this one is 1 and 2 will tend to get this cancer. Blondes, red hair, okay, and then previous basal cell carcinomas, you can have it again. Immunosuppression, okay. So immunosuppression has a very important etiology whereby you tend to get more infections with that. And if you get an infection with an oncogenic virus, for example, human papilloma virus, then you can get basal cell carcinoma, okay. Immunity also helps with getting rid of cells which have damage. So if they have any sort of damage, they're usually the cells are presented and then they're killed off by natural killer cells. So if you have immunosuppression, then these cancerous or cells which are trying to be cancerous tend to proliferate without being affected. Okay. So the UV light, I don't think I mentioned this, but the UV light causes direct DNA damage or causes the release of reactive oxygen species, which now cause damage to the DNA. So that's how you tend to get that cancer. So we have this syndrome, which is quite rare, the Golling-Glotz syndrome, sometimes called the basal cell nervous syndrome, or the basal carcinoma, the basal cell carcinoma syndrome. Okay, usually an autosomal dominant syndrome, which affects different parts of the body. So you can have bony issues, things to do with the eye, neurologic abnormalities. So they tend to have multiple tumors, like the retinoblastoma problem. So in this case, you have an issue with the patch 1 protein. I don't think anyone's going to ask you, but that's what is usually happening. And then, which is the patch 1 protein is involved with tumor suppression. So if you have a mutation in that, then tumors tend to proliferate. Okay. So in Kenya, this basal cell carcinoma is more common, especially amongst the albinos, and it affects the face and the shoulders. So again, it's a rare malignancy in Kenya, but everything is similar to what we see in Caucasians. There's nothing much different. It's just that the epidemiology is a bit, the prevalence is a bit less. Okay, so just to recap, it is a slow-growing malignancy that tends to affect Caucasians, rarely metastasizes, but of course, because it's usually around the face and sun-exposed areas, it tends to have, tends to bother patients a lot. Okay. So how does it present? You tend to have this classic appearance. So this is an old lady who got this. Again, it tends to affect the middle age, if I didn't mention that, and older. So this is an old lady with a classically rounded borders and ulcerated centers. Okay. So usually it starts as a nodule, then ulcerates, and then you have telangiectasia, where you have those small vessels which can be seen, but you won't see it in a darker skin. It grows, continues ulcerating, deepens, then you have these rolled out edges. Okay. As I told you, it is a tear cancer. So you find it along where the tears are. So if this is the lower eyelid, you'll see it growing along this line. You'll find it here up to the lower cheek, even on the side of the nose, on the tip of the nose. So it comes down like that. Okay. Is that okay? So it will be an untender growth, usually dry and slow growing. Okay. So these are the different types. I won't bother you too much in trying to know these types. This is something that you can go and check up on your own. If someone asks you this, then you're really doing well in your exam. Okay. But you have different types, and they tend to have different appearances. Okay. So for example, this could be the nodular, you could have a nodule and then a cyst. So that becomes the cystic basal cell carcinoma. You could have this, we talked last time, like 2 weeks back, we talked about drying of the skin. So you have the scleroform or sclerodermal form basal cell carcinoma. So it just appears flat. You have this one, which is, I don't know how to call it, but you have like micronodules appearing. So that's another situation. And then this one is infiltrative. So you have this flattened appearance, but still growing with multiple nodules, tends to bleed. So that is infiltrative. And then these are the telangiectasias I was telling you guys about. This one in the abdomen is usually called fibroepithelioma. So it's a type of basal cell carcinomas, which tends now to appear in not the sun-exposed regions. So maybe that is one you should know in terms of the fact that it doesn't appear on the sun-exposed regions. Okay. But that's how it tends to present. So how do you test? You'll have to do a biopsy. based on where it is, you might want to do an X-ray to see whether there is further growth, especially the infiltrative types. And then the CT scan and MRI are usually used to tell us whether there's any further invasion. Okay, this is mainly for staging. So based on where it is, it can go into the orbits, it can invade the facial nerve, the bones, the bones of the face, and the parotid gland. Okay, so the staging is very similar with what we do in squamous cell. So I'm sure you guys are aware of the TNM, where it is tumor, N is lymph nodes, and M is metastasis. So the X means it was not evaluated, assessed. 0 means that there's no evidence that any of it has happened. Okay, so when you're talking about T1, we're talking about the size. So we tend to look more at it. So the tumor is like less than 2 centimeters. And you're talking about stage 2, it's more than 2 centimeters. And then stage 3, so when you're talking about stages, stage 1, it is less than 2 centimeters, and there's no metastasis, there's no lymph node involvement. Okay, so for stage 2, it's more or less the same. It's more than 2 centimeters, but there's no metastasis anywhere. So you can't see it in the lymph nodes, and does not metastasize distally. In stage 3, it tends to now it's any size of tumor. It can even be less than 2 centimeters. We saw the infiltrative type can be very small. It can be any size, but there is involvement of a lymph node, and there is extension. There's an extension into the maxilla mandible orbit and the temporal bone. Okay. And then stage 4, of course, is distal. This distal metastasis. Okay. So how do we treat these patients? We tend to, for surgical treatment, we excise the tumor, and this is where now the differences is. Okay, so if the tumor, if the tumor is stage 1, which is less than 2 centimeters, then the margins, how far do you go past the tumor, is around 3 millimeters. If it's more than that, you go 5 millimeters. Okay, so that is how to excise it. Okay, in terms of what is a Mohs surgery, I don't know whether someone has heard of a Mohs surgery. Do you have anyone here who's heard of it?
Yeah, I've heard of it.
Okay, yes, tell us.
I think it's whereby you do the surgery concurrently with the pathologist. So as you size, the pathologist tells you whether they are positive or negative margins.
Mm-hmm.
That's what I know.
Okay, yeah, that's basically it. It's a very common tumor, way of excising cutaneous tumors in the West, whereby you resect. The horizontal sections are examined by a histopathologist. When there are no traces of the tumor, then you're successful. So you can actually go in for a procedure, 10 minutes, sorry, not 10 minutes, like 30 minutes, and then it's done. Or you could be there for 2 hours just digging and digging and digging. Okay. Yeah. And then there's electrocautery, and then cryotherapy, which we talked about the other time. You also have radiation, which is usually used for tumors up to 5 centimeters. And in this case, we are talking about stage 2. Those are the ones we tend to do, those ones, and for whom surgery is contraindicated. So this could be whatever reason why surgery could not be done. Okay. We also have laser, especially for the superficial basal cell carcinoma. And then you have medication. So now this is where the multidisciplinary comes in, and you might have to involve the oncologist. Okay. So like the 5-fluorouracil tends to activate the tumor suppressor protein P53. And then the others are also involved in trying to modulate the immunity to try and get rid of the cancer itself. Okay. So that's the interferon alpha and then imiquimod. So when is it, what do you see that are red flags for bad prognosis? The tumor is quite large. Okay. Most of the time, it's more than 2 centimeters. The tumor site, the central face has a very high risk of recurrence, but also what else is worrying in the central face? Kasim, what is worrying us in the face, especially the central face?
Is it spread to the CNS?
Yes, that's why you're worried. It may go through the cavernous sinus and find its way inside your brain. Okay. Poorly defined margins is another one. If in the histology we see perineural or perivascular invasion, means it's likely to spread. And if it comes back again, especially for the genetic ones, we're quite worried. And immunosuppressed individuals, okay, because it's easy for it to metastasize. So the next one, I told you this thing is very quick. Squamous cell carcinoma, cutaneous squamous cell carcinoma is a cancer that originates from the other epidermal cells, so the keratinocytes. Okay. And in this case, you have the growth of the keratinocytes is unregulated. Again, the most common cause is UV light radiation, even the turning lamp and therapeutic UV exposure. I'm sure you guys have done therapeutic UV exposure in therapeutics. You guys are doing therapeutics right now. So that can be a source for irradiating, ionizing radiation. Okay. So this causes P53, which is a tumor suppressor gene mutation. Remember that the other one, it was patch 1. Okay. This one is P53, which allows the cells with damaged DNA to replicate. P53 is the gatekeeper. I don't know whether I talked about this last time, but P53 is the gatekeeper of DNA. So in the cell cycle, when there's DNA damage, the P53 increases in amount. It either causes apoptosis, stimulates the DNA to be repaired, or it, what else does it do? It just stops the proliferation of the cells. Okay. So it tends to affect individuals with prolonged sun exposure. This is prolonged, should be taken with a pinch of salt. So this should be guys, what do you call this? Fair-skinned individuals. We should mostly be, this is mostly for fair-skinned individuals. Aging, chronic wounds. Okay, this is why we talk about the Majoli's carcinoma. Chronic inflammation, infection, and scarring. Goes back to chronic wounds, immunosuppression, and then you have Bowen's disease. Okay, Bowen's disease is squamous cell carcinoma in situ, and then you have the keratosis, which I think we talked about last week, and then previous basal cell carcinoma. So basal cell carcinoma, previous one can predispose you to getting a squamous cell carcinoma. There's something that I probably did not mention in the other, in the basal cell carcinoma, was this xeroderma pigmentosa, which is it's a genetic disease whereby you have impaired ability to repair UV-induced damage. Okay, so this is another risk factor for most of these cutaneous malignancies. Okay, again, this is the second time I'm mentioning when you're talking about immunosuppression, human papilloma virus. Okay, that's a very important thing to correlate. Okay. Again, in squamous cell carcinoma, cutaneous ones, for darker individuals, it tends to appear in non-sun exposed areas. Okay. How does it present? You have these patchy plaques, open sores, and which can become crusted and bleed. Okay. We'll have more pictures on this, but it tends to have this crusty, like infected appearance, which can kind of bleed. So the common areas is the scalp, okay, sun exposed, remember, face, ears, lower lip, the dorsum of the hand, okay. So they tend to have these pre-malignant lesions, like this interdermal keratinic lesion. We talked about this last week, I hope. Actinic keratosis. Okay, so that could be a pre-malignant, but it doesn't mean that once you see that, you will have the squamous cell carcinoma. But this is the most common pre-malignant condition. So again, the patients must be assessed for regional lymphadenopathy because it could spread, of course, and cause lymphadenopathy. So Bowen's disease, we said, was squamous cell carcinoma in situ, usually well demarcated. You have this, you see this scaly, dry appearance, darkening. That is what you tend to have, these patches and plaques. That's what you tend to find. Next. So there are subtypes. Sorry. It seems like there's a slide that is missing on your end or there. Yes. So this is what I wanted us to focus on. So you have this induration in the, you have this bleeding, and then it has now clotted. You have this indurated edges on the side. This is now the upper eyelid, the squamous carcinoma of the upper eyelid. You can also see that it's also preauricular on this end. And that's why we want to do good lymph node examination in this kind of patients. Ulceration is very common, as you can see. So when you have a well differentiated lesion, it will tend to be dry, firm. You have papules and plaques and nodules. Okay, so you tend to have this kind of appearance. Okay, there might be ulceration or not, but that's neither here nor there. But when it becomes now poorly differentiated, now you expect this fellow over here or this guy. This is Majoli's ulcers. It tends to have this fleshy appearance. It looks like the pyogenic granuloma, which we talked about 2 weeks ago. Okay, they don't tend to have, as you can see on the edge, you don't have these rolled out edges, these dried edges on the side. We don't have that. Okay, so they tend to just have a clearly defined edge, which with a fleshy bed. Okay, they may range. The symptoms usually range from asymptomatic when it's starting to painful, pruritic, can even become infected. Now you have mouth odors, different colors. And if it invades this particular area, for example, if it invades this area, let me ask, Crystal, yes, Crystal, what do you think would happen if we invade this area? What would happen to the forehead?
If you invade that area.
Yeah, this forehead, the right side.
I think ulceration, further ulceration. Not too sure.
Okay, what do we tend to find here? We have vessels and veins and nerves. So if you go into that nerve, what would happen?
You have some facial nerve palsy.
No. The facial nerve is coming from here.
Oh yeah.
You just have like paresthesia. So this side of the forehead, this guy won't feel anything. Again, if it goes into the blood vessel, although the scalp is well vascularized, this area could now become necrotic. Okay, and that is why on this other end, you find that if it invades these tissues, the wound grows very quickly. Okay, on the scalp because of the necrosis. Okay, so you could have a numbness, especially if it is going to motor nerves like the facial nerve in this particular case. If it affects cutaneous nerves like what I just talked about, then you have paresthesias. Okay, again, if it goes into the eye, then you have visual issues which are coming about, right? Again, we have different types. Again, I will not try to bombard you with a lot of information about this. maybe what I could talk about is the Majoli's ulcer, which is another rare type of squamous cell carcinoma. And it takes a very long time for it to develop. You must be having this chronic wound for a very long time, up to 10 years, sorry, 30 years, for you now to start talking about it becoming a Majoli's ulcer. Okay, so it usually ulcerates initially, then you have nodules developing, and then the excessive granulation tissue, elevated wound edges. So with time, it goes from a chronic ulcer, chronic leg ulcer, to now becoming a problem of a carcinoma in 30 years. Okay, so it's very common with chronic wounds and scars. Now the problem is the moment it does arrive, it's a very aggressive type of squamous cell carcinoma and has a very poor prognosis. And it tends to recur even when you do everything that you might do surgically. Okay. Another one is which one is very important for us to know here? You have the cutaneous, this one is labeled here, the cutaneous squamous cell carcinoma of the lip. We said it's usually on the common lower lip. And then you have the verrucous carcinoma. It tends to have this cauliflower, I didn't put it here, but it has a cauliflower appearance, like an outpoaching. And it looks, sometimes might even look like warts. Okay, it goes in the oral mucosa, rectal, and the foot. So you might see it in different places, but it's very rare. Okay, the last one, which is this one, which looks like pus, is the lymphoepithelioid-like carcinoma of the skin. It's a type of squamous cell carcinoma. And it has that abscess-like appearance. Okay. Also, it tends to be poorly differentiated. It has a lot of lymphoid infiltration, and sometimes can resemble nasal pharyngeal carcinoma, which I think one of my colleagues is taking you guys through. Okay. So for the tests, the same as basal cell carcinoma. So refer back to that. Staging, the same thing. In terms of the therapeutic options, what I want you to note right now is, remember the 2 centimeters? In this case, instead of the margins being 3, it is 4. Okay, so for basal cell carcinoma, it is 3 for less than 2 centimeters. But for squamous cell carcinoma, it is 4 millimeters in terms of the margins that you offer to these patients. Okay, most of the time, if you do that margin, you'll have 95% success in terms of complete excision. If it's more than 2 centimeters, then in this case, we do 6 centimeters instead of 5, like in basal cell carcinoma. Okay, so those are the small details which are different. Poor prognostic feature, size, if it's larger, the depth of invasion also tends to be another prognostic feature. Histology, if you have poorly differentiated, then you have a poor prognosis. If it has perineural and perivascular invasion, poor prognosis. Immunosuppression, again, tends to point to recurrence and metastasis. If you have the previous squamous cell carcinoma and even basal cell, previous squamous cell carcinoma, then there's a high risk. Okay. So the last one, which is the biggest problem that you might now face in our setup, it's very fatal. Huh? It's very fatal. It's more common than the basal cell carcinoma in our region. It tends now this one tends now to invade lymphatics and blood vessels. Okay. So in this case, it's a cutaneous tumor that is arising from the melanocyte. Okay, I don't know whether we did this in Burns or where, but there's a slide that I put the cells that you find in the epidermis and the dermis, and try and remind yourself. Okay, so you have keratinocytes, melanocytes, and the Langerhans cells. Those are cells that you need to realize that cancers can arise from these things, and even Merkel cells, right? So when I give you these 3 ones, it's because they're the most common that you might see, but there are more because there are different cells within the skin itself. Okay. They tend to have some precursor lesions, which are we tend to call them nevus. So you have the common acquired nevus, dysplastic, congenital, and cellular blue nevus. Not many people will go into details about this one, but I would advise you to just take your time and probably look into the different nevus and how they appear. What they tend to now ask you is, how do we end up with a malignant melanoma? So these ones, most of the time tend to be de novo malignant transformation of healthy skin of the melanocytes. Or you could have, again, the UVA irradiation. And you have two growth phases. So you have the radial and the vertical. The radial is horizontal growth. I don't know if I have an image. It's horizontal growth between the dermal and epidermal junction. And the vertical growth it grows deeper into the dermis. Okay. So who does it affect? Again, still the light-skinned, fair-skinned, the fair-skinned Caucasian people. What do you call this? And in the US, there's been an increase in amount just because of the tanning. In Kenya, we have this was done by one of the consultants in the department. It tends to affect females more. The average age is 62, which is elderly. They say middle age, but it could also be elderly. Internal medicine gives different ranges for ages, but to be safe, just say it's around 6th to the 7th decade of life. That's when you tend to see these things. And the common histological type is the acral lentiginous melanoma. So we'll see the different types. So this is the one. So if they were to bring an MCQ, these are the things that now they might ask you. So A, which one is true about dash, 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 dash? It's seen more in females or males. It's seen in the 7th decade. Which one is the most common? So these are the points that they might want to ask you. In terms of the risk factors, I've listed them in between here. I talked about the Fitzpatrick skin. You have type 1 and type 2. You have an increased number of nevi if they develop in adulthood. So you didn't have this nevi when you're born. They are dysplastic in nature. There's a family history of any cutaneous carcinoma, and you have a repressed immunity. So these are things that you can't do anything about. Okay, especially let's say if it's HIV, maybe you can modify it a bit actually. This one should be on the other side. Modifiable UV light radiation, so just covering sunscreen and all that and protecting yourself. What occupation do you do? So if you tend to put this star, and we talked about this when you're talking about this thing really burns, and then you have pesticide use, and then not being vaccinated with BCG. So you tend to find a higher number in countries where BCG is not mandatory. Okay, so the commonest symptoms is mainly swelling and ulceration. Okay, and it tends to be in the lower limbs, especially the foot. The left is affected more than the right. I don't know why, but that tends to happen. Okay. So what do you call this? Again, there's something called a dermoscope. I didn't put an image, but these are the results of the dermoscope. So it's like you put a microscope next to the lesion, and then a dermatologist reviews them. So they might be able to tell you these things. So we have this ABCDE criteria. You have this ABCD criteria whereby now when you're talking about malignant lesions, you have asymmetry. So if you cut it into half, they don't look the same. The borders are irregular. The colors they are variegated. So you have different colors. The diameter is more than 6 millimeters. And there's usually a change over time. Okay, so it starts like this, but in 3 months, it doesn't look the same. So that is when you now start being suspicious. Okay, so when you're trying to take your history, you ask the patient. Remember Michelle asked last time about long case. When did the lesion start? Okay, so the onset, when did it start? Did you have any other lesion before this that looked like this? Have you noticed it? Has it changed over time in terms of shape, size, color, any other symptoms? Is it bleeding? Is it itchy? What is the family history in terms of skin cancer, in terms of skin lesions, in terms of skin pathologies? So have you been burnt before? Okay, burning, we talked about burns in squamous cell carcinoma, and that can be a sequelae. Okay, what does this person do? What is their occupation? What have they been a tanning? Do they like using tanning beds? We don't find tanning beds as much here, but you might find people who travel a lot, either to Malindi, Mombasa. They might have this. They might have that history. So you need to find out, what does this guy do? This guy's a businessman who's constantly in Malindi and back and all that. These are things that you need. So the small details that now separate you. Did you get any severe sunburns when you're a child? Okay. Then we talked about xeroderma pigmentosa. You have also the melanoma syndrome, and then you have atypical moles, which are this plastic nevi. Is this patient immunosuppressed? Are they HIV positive, or are they taking immunosuppressive medication for the sake of a transplant that they got? You'll actually find a lot of immunosuppressed individuals, especially in these modern areas. Is it modern or metropolitan areas? Because of there's an increase in uptake in transplantation. There's an increase in lifestyle diseases. So that's why most of people tend to get these transplants. Okay. All right. And UV therapy. We said those are things that you should have been taught in therapeutics. 1 second. Okay, sawa. As I've said, there's this dermoscope which will give you this appearance. Again, there's this ugly duckling sign. So one of the moles goes rogue, if that's the right word to use, and pops out of the group. So you have multiple moles or nevi, but this one pops out and is irregular in shape, becomes asymmetrical, has multiple colors, even starts bleeding and all that. You should be worried that now you're dealing with a melanoma. Okay. So the different types are the superficially spreading. They usually tend to appear as dark spot, asymmetrical borders and changes in color. Then you have the nodular, so it tends to be raised. I think we had one in the previous slide, sorry. You have this nodular appearance. Okay. And then the acral, which we said is the most common in our region, tends to have growth in the palms and the soles of the feet. Okay, and then you have the lentigo maligna, sorry. Usually irregularly shaped brown spots, which tends to grow over here. So this is a slow type. Okay. The superficially spreading is the most common, basically globally, but in our region, we've talked about the acral. Okay. And usually tends to come from an existing dysplastic nevus. Okay. The nodular one is one you should be worried about because it tends to grow vertically. Okay. Rather than radially, so it's going downwards. So which we said has poor prognosis because now it can invade vessels. For the lentigo, it's slow progressive, usually it's unexposed areas. Okay, and this is a good one. This is the one you might want to have. Okay, the lentigo, we said, is in the palms and the soles of the feet. You can also find them in the nail beds, so subangular spaces, usually very painful. And they tend to appear with this black one line. Okay. So you have multiple others. These are just the ones, the typical types that you find. You can even find melanocytic. So they don't have pigment, so they're very rare. And then there are many others that you can get, okay? But these ones are the ones that you should basically be able to tell someone. Staging is now different compared to the others. What I want you to know, if this image is very complex, or you can sit down and dissect it. And when you dissect it, what you tend to realize is from T2, which is now here, where it's more than 1 centimeter, sorry, 1 millimeter, but without ulceration and without any nodal involvement and metastasis, that is stage 1. Okay, so it is up to 1 centimeter, but there's no ulceration. So it can be, you say it is T2 without ulceration and nodal and metastasis. For stage 2, it can now be T2, but with ulceration. Again, still no nodal involvement and metastasis. You'll find that this pattern is very common with most cancers. Stage 1 is usually a smaller size. Stage 2 is a bigger size, but still both 1 and 2 have no lymph node and there's no metastasis involved. Okay, and then you'll find now stage 3, we now introduce lymph nodes. So most of them will have that. It doesn't matter what size the tumor is, but there's some lymph node involvement, which is the same in this case. And then in stage 4 is that it's metastasized. Okay, so this might not be our discussion, but if you use that principle, you can easily get away with staging breast cancer. I hope you guys are taught breast cancer by the general surgeons. So again, I forgot to mention that when it's smaller than 1 centimeter in terms of depth, okay, by then this 1 centimeter that I was talking about was in terms of depth, and we talk about the breast loss depth. So there's 0 all the way to 5 millimeters. Okay, so that's the depth, and it tends to guide us in terms of how to excise these tumors. So if it's less than 1, we tend now to use the Clark's levels. Okay, to try and guide us, how long will this patient stick around in terms of prognosis, and what do you call this in terms of staging? Okay, so that's when we're trying to use Clark's, because less than that, it's very difficult to stage it. Okay, so again, so level 1 is within the epidermis. As you can see, it's within the epidermis. Stage 2, it has crossed into the papillary border, right? Stage 3, it is now between this is usually called the papillary dermis and the reticular dermis. So it's coming to that junction. Stage 4, it has gone all the way to the reticular dermis, and then stage 5, it's now in the hypodermis. So it's even past the skin. Okay, and the survival rate decreases with age, with depth, with that depth. So how do which test do you request for? We start with an excision. So partial thickness or shaving biopsies are contraindicated because you might increase the risk of it spreading and recurring. So if you're going to excise it, remove the whole of it. So excision is usually part of the treatment and part of the investigations, okay? And when you're excising, another good thing is injecting a dye. This is what we call sentinel lymph node biopsy. We inject it to the dye. Usually it's a radioactive dye. Sometimes you can even use methylene blue. And then this now travels, it's drained by the first lymph node, which is the sentinel lymph node. So what do you call this? So during the operation, the first, that first lymph node which drains that particular area is biopsied. And then we now look at it. Does it have signs of melanoma in the first lymph node that drains it? If it does, it's positive. And this case, you have to do complete lymphodectomy. So all the region that would be supplied by that particular area. So when you're learning about this was probably mostly in first year, but when you're learning about where to find particular lymph nodes like preauricular, postauricular, and finding out what areas do they drain. So this is where you apply that. So once you found the first one, if it's there, it means that the others most likely are suspect and you need to remove all of them. So a wise thing to do is actually to do both of them at the same time so that someone doesn't have to do resurgery. Because again, you remove the lesion, you go do histology, and then you come back saying the sentinel was positive. By that time, probably it has already spread. So it's always good to do both of them at the same time. If negative, then you don't need to do a complete lymphadenectomy. Okay. So this is how you go about it. You infiltrate. I'm sure you guys have infiltrated these things before. And then you lift everything up to the subcutaneous tissue. Don't leave anything behind, no partial thickness, full thickness plus the subcutaneous tissue. All right. Okay, so when you get to stage 3, and mostly stage 3B, we want to do, because there's some lymph node involvement, we might want to do other tests. Okay, like the CT abdomen, CT chest, CT pelvis, even the head CT, just to confirm that this lesion has not spread further. Okay, so stage 3 and above, because of the lymph node involvement, you might really benefit by doing further investigations just to confirm it has not spread further. Okay. We've talked about local distance control. This is when, so after you've seen that it's affected the lymph nodes, you will do the CT scan and then see where it is and then try and excise in those particular areas. Okay. So if there are any lung deposits, you remove them. If there are any brains and GIT, they tend to be removed, but most of the time now you're dealing with palliation, and radiotherapy may be very beneficial in terms of pain management. Okay. So in terms of malignant melanoma, we talked about the basal thickness from 0 all the way to 5. So when it's within the epidermis, we call it in situ. When it is less, when it has now passed, and now we're talking about the different depths, it tells you how do I resect, or what margins do I have. As you can see, these margins are more than the other two that we've done so far. What do you call this? You have 0.5 for in situ, 1 centimeter for 1 millimeter, it's 2 centimeters up to 2 millimeters depth. You do 2 centimeters. If it is 4 millimeters depth, up to 3 centimeters, and up over 4 millimeters depth, it's 3 centimeters. So this, just interact with it and internalize it. These are nice MCQ questions. You tend to see this in MCQs, and especially if you're going to do any international exam. That is, if you're going to India or UK, or you want to do the USMLEs, these are questions that they like asking in step 2. Okay. Poor prognosis, the depth is very important. The farther it is, the poorer the prognosis. Even Clark's invasion, ulceration is also a bad sign. I don't know whether I mentioned this, but malignant melanoma doesn't respond that well to chemo and radiotherapy. So surgical treatment is usually the main way of managing these patients. So yeah, the older you are, males tend to have worse overall survival compared to female counterparts. Where is it? So is it next to a vein? Is it next to a nerve? That tends to affect the prognosis and how big is it? What are the surgical margins? The bigger it is, the less likely it is to recur and to have many issues. And then histologically, the mitotic index, is it actively dividing? how did it grow? If it went vertically, then poor progression. Okay. So the tumor, the spindle cell has a better survival, has a better prognosis. So the spindle cell is the one which look like pus, this one. Did I have a picture? Oh, I did. Oh, yeah, no, it's one of the, it's one of the types. So it's the dysplastic type of melanoma. That tends to have a better prognosis compared to the others. Another one that would be very beneficial for you guys to know, you'll rarely see it in Kenya. It's called the Merkel cell carcinoma. And it comes with the Merkel cell polymovirus. I think that's the name. So it tends to come after an infection. Okay. So this is something that you could benefit from knowing when you're done reading. So we have, these are the references. You can up to date, use this book and then this book for the images. So let's do a few questions and then I can be on my way. Vincent, confirm that you guys are able to see. Vincent?
Yes, Doc, I think we can see your screen. We can see the questions also.
Okay. So we have a patient called Duku. So we have a patient called Nduku who presented with an indurated scaly papillonodular lesion about 1 centimeter in diameter on the forehead. What margins would you need for complete excision of this tumor? That's the question that I'm asking you guys today. Okay, so anyone brave enough to tell us what they put? I'm seeing these mixed reactions.
I chose 4
Mhm.
because I thought this would more likely be a squamous cell
Yeah.
carcinoma
Mhm.
based on the papillonodular characteristic and where it is on the forehead.
Mhm.
So, and you said the margins are 1 millimeter more than the basal cell one. So I chose 4.
So in this one, the answer is 4 millimeters. It is actually basal scale as she said. Sorry, it's squamous cell because again, scaly. Remember scaly. Once it's scaly, just remember that. Okay. And again, as she said, the margin is less than 2 centimeters. So the size of the tumor itself, the diameter is less than 2 centimeters. So the margins will definitely have to be 4 millimeters. Okay. That is if you're doing an excision. The best way to treat these tumors is more microsurgery. It's about this one. So Wangoi with Golling's syndrome presents with what does she present? Nodo-ulcerative, okay, with telangiectasia lesions on the left lower lip. What is the origin of this tumor? I'm seeing majority of you have gotten it. I don't know. Does someone want to tell us why they chose that? Vincent, what did you choose?
I chose basal cells of the epidermis.
Why?
I think you said that it can also be called the basal cell nervous syndrome. So basically, it means that it originates from basal cells. And also, I think that.
Okay, great. Yes. Also, if you look at the way the tumor looks, you have nodo-ulcerative, very characteristic. Even if they don't put for you this syndrome, for sure, it's most likely going to be that with the telangiectasia, very common with that type of tumor. But with Wangoi, not unless she's very light skinned, you might not be able to see these small vessels. Okay, so let me do the last one. Are you able to see?
Yes, you can see.
Okay, so Someone has turned. Nikita, you've turned on your camera. It seems like you want to say something. Nikita, what answer did you give?
I went with Breslow thickness.
Okay, so that's the answer. So staging does not really tell us what the margins are. Staging just tells us, do we need to do more distal metastasis control? Okay. Clark's depth, not really used in terms of knowing the depth. In terms of, it's used mostly when this one is difficult to tell. Okay. Location of the lesion does not influence. So the next question is the last one. Invasion into the reticular dermis is which Clark's level? Today's questions are very easy. Vijay, what did you answer? Varad Vijay. Albert Chebulukot. What did you answer? Hmm? Patrick Ochieng, what did you answer? Patrick? Okay, anyone else? Anyone who answered?
And I think it's Clark's level number 4.
All right. With that, I am done with you guys. Best of luck in your exams. Are there any questions? Doubts?
There are no any questions. I
Ah,
think I would like to convey our gratitude for the tutorials. I think they were quite splendid and very helpful to all.
I have a question before Doc you leave.
Alright.
Going back to the lecture on wounds and
Alright.
classification of wounds, when you explained to us the different classes of wounds, there was the difference between clean and clean contaminated and contaminated. We talked mostly about perforation of, involvement of the colon. I just want a clarification. Is clean contaminated where there's spillage of colon contents, but it's contained, or it's just not touching the colon at all? Because there are different doctors with different opinions.
I think, what you said, it's the clean contaminated is when you enter a hollow viscous, but you've controlled whatever is within that viscous. Contaminated is you have uncontrolled spillage from that particular viscous. I don't know whether have I helped.
Does it involve surgery to the colon?
Yes. So in clean contaminated, you're entering any hollow viscous, which is anything in the GIT, in the GUT, biliary tract is opened. Everything is opened. But whatever comes out of it is the spillage is controlled. But in contaminated, it could even be elective into the colon, any hollow viscous, GIT, GUT, and in this particular case, there's still gross spillage, which is not controlled. So in this particular case, the wound tends to get inflammation, infected, all that stuff.
Okay, thank you.
Yeah. Anything else? All right, guys. I just want to tell you, I think your exams are in 2 weeks, yeah? Vincent, if I'm not wrong, I'm not so sure.
Yeah, they are from next week, part 1.
Okay, so from my end, what I would want you guys, you can unmute. Sorry. So what I would want you guys to be able to focus on, we've done 11 heavy topics. But since you guys are in 60 and you have a lot of stuff that you have to read, we have plastics, you have orthopedics, you have ENT, you have all these units, internal medicine, therapeutics, all of them demanding time from you guys. What I would highly advise you take the major concepts from, like now what I've taught, which is the plastic sides. Make sure that before you go for that long case, you are aware of what a wound is, classifying wounds, which is good, we've just reviewed quickly, classifying those wounds, surgical wounds, being able to manage. So remember those principles that I gave you for managing wounds. When you talk about burns, don't enter the exam without knowing the pathophysiology of burns and without knowing how to manage burns in terms of fluid therapy, because that's what you'll be doing as an MO anyway. Most of the time, before the consultant comes, you'll be the one there. So you should be able to quickly give the right fluid resuscitation. Okay. For soft tissue infections, make sure that you know your penicillins and your ceftriaxones very well. These things you learn in therapeutics, know the different options that you have. And that's why when we had that class, I was telling you, go and check up on it, because those are things that you will see in different hospitals. Different hospitals will have different antibiotics. So you need to be able to know the penicillins very well, the ceftriaxones. What happens if you're allergic to any of them? What do you do? And in terms of necrotizing fasciitis, and necrotizing fasciitis is something you cannot get away with not knowing, right? For the tumor series, don't enter that exam without knowing Kaposi sarcoma and malignant melanoma. You might survive if you don't remember basal cell and squamous cell carcinoma, but for sure, whichever exam that you go to that is surgical, especially for your finals, there will be some malignant melanoma or there will be some Kaposi sarcoma. Those are things that you should expect. In terms of the benign lesions, you might not get people asking you about defined papillomas and all that. It's more of to help you be able to describe different cutaneous lesions. You won't find a lot of essays and maybe some MCQs here and there, but 60, I think most of you guys already know. I think you have like 3 months to go. It's about the big topics. So even as I'm done with you guys, make sure that when you go to your next tutorials, whether it's ENT, Gen Surg, or Neuro, I don't know whether you guys have cardiothoracic, make sure that they tell you what are the big topics that if I enter the exam, I will be messing myself, because 60 is all about the big topics. Make sure that the big topics you know, and then these other small units will boost your marks now from maybe a 70 to a 75 to a 80. Okay, but if you understand the basics, or if you understand the big topics, because there's so much to examine you in 6th year to prove that you're a competent doctor. So you have to ensure that you enter an exam. Don't enter an exam without knowing how to calculate total body surface area for burns, because you'll just embarrass yourself. Okay, so those are the things. The major topics, make sure that you know. For Gen Surg, ask your tutorial guys. For ENT, ask them what comes in the exams. Those are the things that will save you, so that you don't waste a lot of time cramming. For example, like in the benign cutaneous lesion tutorial, some of those things are very new and you might not see them. So you might take a lot of time on them and you don't know the pathophysiology, or you don't know what the Clark's, what Clark's levels is. Then you mess up for yourself going forward. But otherwise, good luck with your exams and your long case and your end of years. If you have any questions, you know where to find me. Sawa sawa.
Okay, thank you so much.
Okay.